and I will introduce you to Alison Leary, who's very kindly offered to support us this afternoon by sharing her wealth of knowledge and expertise in this area with enhanced practice, what it is and what it isn't. And I must admit, I'm really looking forward to this part of the day. So Alison, I will hand over to you. Thank you so much.
Thank you very much, and thanks for inviting me. It's hopefully you can see that, and yeah, so I'm going to talk about what enhanced practice is and the original modelling that underpins it, because I think that might help people kind of understand it conceptually. It's something that is not new. It absolutely is not new, but I'm going to kind of explain why it was done. So I work at London South Bank University and for the WHO, and this is really about a workforce that already exists and actually is really, really important, but really just didn't get any credit, and was actually a very big risk in terms of losing that workforce. So I'm going to just... So in March 2019, so before the pandemic, everything before or after the pandemic, I think these days, the complex work of people like nurses, AHPs and other workers like pharmacists was going actually pretty much unrecognised in policy. And what we were seeing was this like very large functional workforce that was really, really important, but didn't have any specific boundaries in terms of areas of practice, populations, organisations, disciplines, roles or professions. It's actually a really pivotal workforce. And we were seeing some challenges because of ACP being implemented. So this was about probably 3 or 4 years after ACP, the job, not the level of practice, was implemented, which was a sort of generic advanced practice role. And we were seeing some fallout from that. And so particularly in people that weren't deemed to be advanced, in terms of investment, and HE approached me and said, you know, what could be done about this? So we started to look at this, and there is this thing about this not being a new thing, and that's, I can't sort of overestimate, but it was a very poorly understood thing. And modelling, if you're a modeller like me, you build representations of the real world, and so we were asked, could we look at this from a modelling perspective? Could we look at this big functional, poorly defined group of people that are pivotal to healthcare, and really think about maybe identifying them and actually giving them some formal recognition for the first time? So that's really what this was about. So we did this by using something called soft systems modelling, understanding the real world, and we iterated that. So we worked with around 45,000 people. We work with 70 different professional groups. The way workforce modelling is usually done in healthcare is very different to other safety critical industries, in that we see a gap and then we throw a new job at it. And actually that's not a great way of doing things when you've already got extremely functional workforces that not only are not being recognised for actually doing that job, but then have to face a challenge of new jobs, new services, all sorts of things. So when you introduce a new job or profession, it's really, really challenging, because there's this sort of jurisdictional aspect of work, and then people have to renegotiate those boundaries and renegotiate jurisdictions. And healthcare, particularly in the UK, has had lots of new jobs thrown at it. In my data set alone, we've got 77,000 different job titles in the English NHS. And that's really, really confusing for people. So we looked at about 45,000 people's work. We did a lot of stakeholder engagement. So all the professional associations, everybody, the College of Paramedics, the Royal College of OTs, the College of Radiographers, the biomedical scientists, everybody was kind of involved in this, including people that use services, so people like patients and families. We tested a model that we built with stakeholders, and then we did a soft launch of it. We didn't sort of land it on the system the way ACP was landed. ACP worked in a few places, and then suddenly people kind of decided to spread it out. And that had a fairly serious impact on the system. We've written papers on that if you're interested. But we kind of iterated this out. So it was more like a kind of snowballing type of thing if you're interested in the methodology. So the important thing to understand, I think, is the nature of work in healthcare. So we would consider healthcare to be a safety critical industry. Policy doesn't always reflect that. Workforce policy models healthcare as if it's a service industry. It kind of throws out lots and lots of newly qualified people and expects them to manage very high levels of risk. And Eric Holnagel is a safety researcher, and he says there's this tension in every industry where you want efficiency and productivity, and you'll see a lot on that at the minute, but you also want the work to be reliable, and you want it to be high quality, and you want it to be safe. And you can't actually have all of those things. If you have to find a kind of sweet spot between that, where if you look at aviation, where they prioritise safety over quality. If you've been on a budget airline recently, you'll see how they perhaps compromise on quality, but you'll be subjected to the same safety regulations. That's not compromised at all. So in many industries, you have to find this sweet spot. In healthcare, the focus is more on productivity. That means doing more work, not necessarily how well that work is done. So healthcare has a very, very big risk appetite compared to other safety critical industries. And the way that we manage risk in healthcare is actually through our workforce. Rather than putting systems in place, we actually manage it through our workforce. And that's kind of the important thing to remember from this. So what we have in healthcare is lots of demand, which we don't really understand. And next to that, we put lots of operational risk, which we also don't really understand that well. Right next to our risk, we put a largely inexperienced workforce, what we call a rookie workforce, people that have been qualified less than 2 years generally. And then we expect those people to make decisions about what gets passed to the experienced workforce. And that's problematic for a number of reasons. So when you've got very, very complicated and high risk and unpredictable work, expecting people with very little experience or fewer qualifications to make decisions generally doesn't end well. So what we get then is people leaving. So we're seeing very, very high turnover rates in areas like nursing. Currently, people aren't staying on the nursing register for very long. This is a poor retention strategy. And it's also a poor safety strategy. If I show you what we call a high reliability organisation would look at, it would look very different in terms of its workforce. So it would understand its demand, it would understand its risk, and next to its risk, it would place an experienced workforce. And this is the enhanced practice workforce in reality. They would then delegate work or pass work back to the inexperienced workers. So this allows the inexperienced workers to then play what Dave Snowden would call the failure games. So you fail and you learn, but nothing's catastrophic about that generally. So your experienced workforce in a high reliability organisation, a safety critical organisation, is the thing that you try to keep. You put lots of effort into keeping your experienced workforce. And that's the thing that really we're kind of trying to do with enhanced practice. Enhanced level practice is really about the experienced workforce. So in safety critical workforce, if we go back to that thing where you're compromising between safety, quality, effectiveness, efficiency, the thing that we do in many safety critical industries is focus on what Benner, if you remember Benner from many years ago, would call the proficient workforce. So you need novices, you need the new people coming through, and you need your sort of people going through their kind of proficient, they're gaining their proficiency. And you need experts, but experts are very expensive. And to be honest, lots and lots of experts are probably not what you need. The thing that you need to help square that circle between being safe and effective and efficient is what we call the proficient workforce. So all the works of Dreyfus and Dreyfus and people like Benner. But essentially, this is sort of how the healthcare workforce kind of sediments out. So the reason for this is in healthcare, what we tend to do is have more of a Christmas tree. And the Christmas tree is really about having lots of people that are, so a small amount of people that are very, very technically competent and expert and proficient. And then as the work expands, what we do is we increase the less experienced or the rookie workforce, or the people with fewer, maybe fewer qualifications. So we have this really high churn at one end, and we don't keep the proficient people at the other. And why is that important? So when you're thinking about delegation, I see a lot of delegation frameworks, and they're usually about technical tasks. So what happens is we have people saying, oh, well, that person's competent to do that task now. And then you see things like skills, not roles, and you hear things like task shifting and working at the top of your license, and all the things from the management consultancy playbook, essentially. But that's not a great thing to do in safety critical work. What we tend to do in safety critical work is not look at technical task competence, but look at complexity and unpredictability of work. So what you want is people that are perhaps newer to the work. They tend to do the high volume, more predictable work. But what you really need to manage safety and manage risk and improve quality and make the work still efficient is you need people that can exhibit what we call justifiable deviance. Now, people who do that are people that work to the rules most of the time, but understand where you have to make different decisions. So we're talking about a frontline expert decision maker of whatever profession or whatever kind of practice that there is. So this leads us on to what is enhanced practice. So it describes the level of practice that is proficient, that proficient workforce that manages risk, increases efficiency, and gives high quality care. They're what we call proficient. And the term enhanced came about through working with all these different groups and asking people basically what they'd like to call it. A lot of professions already have proficiencies in terms of their professional registration. So proficient, even though that's the sort of term in the literature, that was kind of thought of not to be the right word to use. So people liked enhanced. Enhanced was decided on by consensus. And it describes this level of complexity of work beyond that of first level registration. So beyond those people that have been qualified a couple of years, maybe have undertaken preceptorship, and now they're kind of out, they're making decisions, they're managing risk, they're teaching the next generation. That's the enhanced practice workforce. They are a risk managing workforce, and that's the important thing to remember. They have a lot of discriminative judgment. And they, for an organisation, are actually really good value. So you retain frontline expertise and you have this really kind of efficient workforce that gives good quality care. So they're actually really, really important people. So the healthcare workforce doesn't fit into these sort of neat categories. So there's quite a lot of overlap between these things. And also people asked us about, why is this not specialist? So a lot of different professional groups seem to think about specialist, then advanced. Specialist doesn't particularly, unlike medicine, where there's gates into specialism, the healthcare workforce has specialist knowledge at all different levels of practice. So what we did was we sedimented out the healthcare workforce into these different groups to help, but there's quite a big overlap between them. So, and also in terms of scale, what they actually look like is this. So they're not all those nice Venn diagrams. So what we've got is a very, very big supportive workforce in healthcare. And we've also got now quite a big assistive or associate workforce in healthcare. But as you can see, we've got novices. Novices turn out maybe in England 30,000 people a year, but they're not staying very long now. There's quite a lot of evidence that those novices and intermediate workers are not staying for very long. But the proficient workforce, the enhanced practice workforce, is key to success of the system, key to good quality care, key to managing risk, but also workforce that needed to be retained, and it was really not being retained. It was the big leaky bucket, essentially. So that's why this work was really done. The differences are transitional. You don't go from being enhanced to advanced to consultant to, or you might stay advanced, but there's quite a big overlap between the two. And this is some of the things that we mapped out that was kind of the difference between the different categories of kind of worker. And so this was primarily clinical, but it's not just clinical work. So we do it across all 4 pillars. But this was the kind of the clinical focus, because generally that's what people are most interested in. So all of these levels of practice use a lot of what we call reflection in action. So reflection in action is where you make a decision in the moment based on your experience and your knowledge of a situation. You might have been in that situation before. You might have seen somebody else being in that situation. So this is why things like clinical supervision are really important. Developing reflection on action, so thinking about what happened, helps you develop reflection in action so you can make a decision in the moment. Have I lost you guys?
No, I don't know what happened. Try sharing again. The sharing
I'll share again. No, you guys like completely disappeared. So I will come back to. Is that okay?
Yeah, all good. Yeah, just
great. Okay.
Through, yeah.
So I think we were here, weren't we? Da, da, da. So these transitions, these differences are transitionary. People develop across the 4 pillars at different levels of speed and pace, but usually the clinical is the one that people are most interested in. So it's people that have quite a lot of freedom to act, make complex clinical decisions, usually will manage care and do quite a lot of negotiating within usually a multidisciplinary team. So because in a multidisciplinary team, people have sort of boundaries about whose work belongs to who, and there's quite a lot of negotiation that happens and quite a lot of brokering that goes on. Generally, this group were qualified to postgraduate level. So they had postgraduate diplomas, lots of continuing professional development, either formal or informal, and sometimes to master's level, actually. So that was kind of how we kind of grouped this group together. So the levels kind of overlap. So you've got this overlapping, and they encompass professional practice, not just competence. So just want to take a moment to talk about practice. So when you have the big book of competencies of what people are signed off to do, that only really describes one part of the work. And it's really important to think about the different parts of the work. So when we talk about not just technical skill, but applying knowledge and skill in professional practice, knowing when to do that thing, when not to do that thing, that's what we're really talking about when we're talking about the proficient and enhanced worker. So it's really about practice, what we refer to as praxis. So
Alison, are you able to share your slides again?
Oh, I'm sorry.
For some reason they've come
yep.
off.
Okay. Yep, I can share.
Thank you.
I'm not entirely sure why we keep losing them.
Not sure.
But I will try again.
Thank you.
So let's go back one. Shall I leave this up like this? It might be a little bit easier if I just don't put it onto slideshow. And you're very welcome to have these slides as well if anybody wants them. So the issue as well is that praxis it looks through a professional lens. This is one of the reasons I think ACP has struggled a little bit, because in many ways it's about looking through a different lens. So when we see the proficient worker, we also see praxis. We also see looking through the lens of that practice, that professional practice, that different, whether you're an AHP, a nurse, a pharmacist, you have a professional lens that you look through, that you make risk adjustment through. And that's actually really important in terms of enhanced practice. So enhanced practice happens within professional groups. It is not omni-professional the way ACP is. So what we started to do was we started to look at these different ways of looking at this. So you see this matrix in the work, and we couldn't just model the enhanced practice workforce. We had to model the entire workforce to really work out where people were and where people were on that continuum. So that was quite important. And this is where really enhanced practice and those roles sort of kind of came out. So what we saw with advanced practice was this whole range now of what advanced practice is. So you might be advanced practice in your origin profession, you might be a clinical nurse specialist, an advanced practice radiographer, you know, lots of different roles. And then at the other end of the spectrum was more the kind of medical substitute with the more omni-professional roles. Enhanced practice can feed into any of those areas around advanced practice, but also it's a destination in its own right. Lots of people might see enhanced practice as a precursor to advanced practice, but you can stay in advanced practice. The idea that you've got to keep kind of climbing this ladder is kind of a bit of a misnomer, really. So you can develop in an enhanced practice role at that level and keep developing. That's what we would do in any other safety critical industry, and that's to retain frontline expertise. It's actually really, really important. So we started to look at people that sort of self-described as enhanced level practice. So we saw sort of people like some nurses that were working in specialisms, community optometrists. We did quite a big optometry and ophthalmic piece of modelling. People like specialist paramedics with the College of Paramedics. So there are all kinds of different kinds of roles that sort of, as we work with the different groups, sort of said these roles are probably enhanced practice roles. One that really surprised me was reporting radiographer, because it seemed like quite a high risk kind of role. And I would have put that more as advanced practice, but it just goes to show you really that, you know, people will surprise you. So making it happen. So we built the framework for enhanced practice to help people, and people that use the services and people that work in the services understand it. And then there's the apprenticeship, which is the Enhanced Clinical Practitioner Apprenticeship. It's a little bit problematic in terms of what it's called, because apprenticeships have to attach to occupational groups. But there's lots of routes in and lots of routes for development now in terms of valuing that experienced frontline workforce that is made up of lots of different professional groups with that interesting professional lens. And we're seeing now many groups have defined this. So nursing's already, the RCN have already defined this. The Society and College of Radiographers were the first people, I think, to do it, actually. They kind of jumped on board. The CSP's done it, and also the continuing work that I'm sure probably Claire's going to talk about the different professional groups and their different professional frameworks for enhanced practice across the AHP professions. Just to say what enhanced practice isn't, I think it's probably quite important, because I'm really conscious that, you know, things, it doesn't matter how much modelling you do, you release something onto the system and then it changes. And it was
Alison,
really mindful.
Sorry to interrupt you. I think your slides haven't moved on. It looks like we've lost Alison.
If it helps, I'm definitely here, Amanda. For reassurance.
Or you could be brave and answer Vladimir's question in the chat.
So I'll just have a quick look at the chat here. It's just coming to the wrong time and not for Alison. I'm wondering why there's lack of knowledge or resistance to hiring osteopaths in the NHS. I wouldn't necessarily say there's a resistance there, Vladimir. It's from my perspective, it'll be down to local requirements for workforce planning within organisations. So that national driver for any workforce is always then fielded down locally at a trust level or organisational level, and the decisions made about what workforce is required. So obviously there are some osteopaths working within the NHS. They weren't articulated within the long-term workforce plan. Obviously we're going to be having a new iteration of that now. We've had the publication of the 10-year health plan, so we're expecting the autumn of this year a further or a new workforce plan. So I think the lack of knowledge, part of that might be related to obviously there's a lot of different professions that work within the NHS. So you've got your professional body who work really hard. I've worked closely with them as part of the Enhanced Practice Schema, who've been a brilliant voice for your profession. And that's why we've commissioned, with the hope, we had an ambition this year to try to train some osteopaths at an enhanced practice level. So we've certainly, from the National AHP programme perspective, continued to support the profession.
Thank you, Claire, for answering that question. That's really useful for us. What we'll do is we'll move on to your presentation, Claire, because we've obviously lost Alison. So
Absolutely
I will
fine.
move
Back.
you on.
She's back.
What I'll do is I'll answer your questions in the chat if you like. Because there's
I can take you back. Hold on. There you go. That was the slide we were on.
Yeah. So that's absolutely it. There is no enhanced clinical practice. It's about valuing each different profession. Claire's probably covered it. And I'll answer your questions about door hanging and things like that in the chat if you like.
I really want to know about door hanging, please, Alison.
Yeah, so door hanging is termed by Molly Courtney, who did all the work on prescribing. And door hanging is where you know the decision that needs to be made, but you have to get the sanction of somebody else to do it. So you might know that someone needs an MRI, but you can't order the MRI. You might need something needs prescribing, but you don't have the legal power to prescribe. So you're essentially having to utilise somebody else who can sanction that decision, but you've actually made the decision.
That's really interesting. I've never heard of that before. Thank you. Alison, there's another question there, which is about obviously the research and the consultations. So I wonder if when we do the post-event follow-up, we'll try and share whatever we can with you all in terms of accessing Alison's research and the what was included in her presentation. Is that right, Alison?
Yeah, absolutely. You're very welcome to have the slides. Most of this is in the HEE documents, including the research. So including how we did the soft systems modelling for this and all the people that we consulted. They're all in. I'll go and find it now and give you the links, and I'll put them in the chat.
Thank you.
There's a question here from Kim. Kim, you might have to explain a little bit more, but it says, is enhanced practice being used across trusts as the back to advanced, in particular nursing?
What to advanced?
As the back. Kim, do you want to just open your microphone and ask your question verbally?
Sorry, I'm here. So
Yeah.
I'm here. I'm just trying to get it to work. So I think Alison and I have spoke about this before. So I'm just saying, do we think enhanced practice is being utilised as the back door to advanced? So rather than having people kind of in those roles as advanced, using enhanced as that, just a bit of experience that we've been experiencing a little bit of it late, and in that clarity of what it is and what it actually isn't. But utilise more as an advanced model rather than enhanced, developing and extending the skills, say, particularly as a nurse?
Yeah, so I mean, advanced, I think the issue with nursing is that advanced practice isn't recognised in nursing as much. So people are working at advanced practice level, but they're not being, the roles are not being paid. or recognised. So we've seen a big downdrift in people like clinical nurse specialists in terms of banding, and district nursing, areas like that. So I think it's in nursing, it's a different issue. The idea between, so looking at enhanced, do you need an enhanced person or an advanced person? And of course, so this is kind of what organisations need to model, and some have. I mean, places like the Royal Free, I think, have. They did a few years ago anyway. They looked at, is it an enhanced role that I need in that service, or is it an advanced role? So if it's lots of, for example, case management or very complex decision making, completing episodes of care, you generally go for an advanced role. If it's more perhaps working as a sort of more an MDT model, with more negotiation between those roles, then it's more an enhanced kind of role. So generally, there's going to be a lot of people that you want working at enhanced practice level, just because it is so important. So if you're working in, so you find enhanced in nursing in areas like chemo, daycare, areas like that, ward leadership, quite often, some enhanced and advanced kind of practice working. But for nursing particularly, you can look at the RCN's levels of practice, because it's all spelled out now by the RCN. But I'm conscious this is about AHP practice, this session. So
brilliant, Alison. Thank you so much. That's been really, really useful. I know we had some technical difficulties, but thank you for rejoining us. We will share your slides, and if you are able to answer any of the questions in the chat, that would be fantastic. Thank you so much. We're going to move on now because we're going to keep to time.